You've seen the headlines, right? The NHS is in crisis. We hear about long waits, crowded hospitals, staff on strike. But what if all of that? What if those are just symptoms? Today, we're going to pull out the blueprints of the system itself and ask a really critical question. Is this whole crisis an accident, or is it actually the predictable result of a fundamental flaw in its design?
Okay, let's just start with a number. And honestly, this one should stop you in your tracks. 93.8%. That's the percentage of UK general practitioners who are likely suffering from a minor psychiatric disorder, according to one major survey. Think about that. The people who are the very foundation of the NHS, they're in a state of near constant distress.
And this isn't just about burnout. It's something much deeper, what investigators are now calling moral injury. This quote here, it comes from a report about a practice that's become frighteningly normal, corridor care. It's about the profound psychological harm that happens when you're forced to work in an environment where you simply can't provide safe, dignified care. It's the trauma of knowing exactly what to do, but being physically prevented by the system from doing it. And on top of that psychological harm, there's a very real physical danger. Just look at this number, over 104,000. That's how many physical assaults were recorded against NHS staff in a single year. And to put that into perspective for you, that number has more than doubled in just 5 years. The workplace itself is becoming more and more dangerous. So what do we have? A workforce that is sick, morally injured, and physically at risk. These are the symptoms for sure, but they are not the disease. So in this explainer, we're going to go deeper. We're going to investigate the root cause, the architectural flaw that's built right into the NHS's own constitution. Right. Part 1 of our investigation, we're starting with what the source material calls the original break. It's a subtle change made to the system's wiring over a decade ago that basically created a huge, dangerous vacuum right at the very top. And here it is. It looks like a really minor change in wording, doesn't it? From provide to promote. But the impact of this change was absolutely seismic. Before 2012, the Secretary of State had a clear legal duty to provide healthcare. That meant there was a direct, unbroken line of accountability from a patient right up to the minister. The 2012 Act severed that line. Changing the duty to just promote a service meant responsibility could be scattered across a whole network of other bodies. And suddenly, it became a lot harder to know who's really in charge when things go wrong. And this created what our sources define as an accountability vacuum. You see, the power and the money stayed at the top, but the legal responsibility for actual failure, that got pushed down, fragmented, and spread out. And you know the old saying, when everyone is responsible, nobody is. And it's in those gaps that risk is allowed to grow, completely unchecked. So, what happens inside this vacuum? Well, it sets up a mechanism that doesn't just fail to manage risk, it actively pushes it downwards. The whole system, in effect, becomes a giant risk transfer machine. And the key term for this is governance pushing down. It means that systemic risks, big stuff like not enough funding, not enough beds, not enough staff, those risks aren't owned by the organizations making the policies. Instead, they're transferred directly onto the shoulders of individual doctors and nurses on the front line. They become, as one source puts it, the risk-absorbing membrane for the entire system. Let's look at a perfect example of how this works in the real world. It's called the shared care trap. So, step 1, an administrative body, like an integrated care board, issues guidance to GPs. They're told to restrict prescribing a certain complex drug, usually to save money. This creates the dilemma in step 2. The GP is now trapped. If they follow the guidance and stop the medication, as you see in step 3, their patient could get seriously ill. And if that happens, step 4 kicks in. The GP is the one who faces professional and legal consequences for the patient being harmed. The ICB that made the policy, they face no sanction at all. The entire risk has been transferred to the clinician. And the outcome is just impossible. The GP is caught between their fundamental duty to their patient and this top-down administrative strategy. And this analysis really nails it. It creates a state of clinical paralysis, where literally every choice carries a huge professional risk. So, what happens when you take that one impossible trop and you multiply it across hundreds of thousands of clinicians every single day? Well, the result isn't random. It's actually a predictable system-wide collapse curve. This model shows exactly how it happens. You start at stage 1 with baseline system pressure. Then, in stage 2, that risk gets transferred down, and look, the risk level multiplies. By stage 3, clinicians are overloaded. Their capacity to just absorb any more risk is gone.
And that inevitably leads to stage 4, where staff illness and service failure start feeding each other in this critical downward spiral. And if you think that's just a theory, well, the data shows the NHS has been tracking this curve almost perfectly. Look at it. From a stable pressure back in 2015, through intensifying risk transfer, to a peak of clinician overload in 2022. And by 2025, with early retirements surging and more than half of staff admitting to working while sick, the system is firmly in stage 4, service degradation. Let's just pull out one of those data points and look at it. The risk of burnout among doctors didn't just rise a little bit. It more than tripled in just 7 years. This is not a slow, gentle decline. This is the visual proof of that exponential risk curve in action. Now, this level of systemic failure has utterly devastating human consequences. But how does the state respond? Well, think about aviation. A single plane crash triggers a massive, mandatory national investigation. It has to. But in healthcare, a scale of loss that's equivalent to about 37 airline disasters a year is met with fragmented, localized governance. The constitutional machinery that's meant to protect life just doesn't kick in the same way. So, where does this investigation leave us? We've looked at the symptoms, we've identified the design flaw, and we've tracked its devastating path. Let's just quickly recap the core findings. First, this crisis isn't an accident. It's a predictable result of that 2012 law. That law created an accountability vacuum, which then allowed risk to be pushed down onto staff through things like the shared care trap. And that has driven a predictable collapse curve of burnout and failure, putting us right where we are now, in a dangerous phase where harm just amplifies itself. So, when you boil it all down, the evidence is pretty clear. The story of the NHS crisis is not a story of failing doctors or failing nurses. It's the story of a failing constitutional architecture, a system that was designed in a way that makes this kind of outcome almost inevitable. And that leaves us with one last, really vital question. A system that is designed to diffuse responsibility, by its very nature, holds no one responsible. So in an architecture of crisis like this one, who actually has the ultimate duty to step in and protect both the people who work in the NHS and the patients who depend on it?